Dear students, the topics of our next lecture is the root canal obturation. So, first of all, let's say the main functions of root canal filling. It provides a long-lasting barrier between outer and inner space of root canal system, and also it provides a perfect obturation of all of the root canal system, in some more successful cases, even including some ramifications and accessory canals. And also, tooth with root canal filling is able to be reconstructed with respect to the crown part. So these are the main functions of root canal filling obturation. So, which aims of root canal obturations should we have? First of all, perfect obturation of root canal system provide the permanent prevention of the bacteria and humidity penetration to the root canal system. The next aim that the root canal filling should prevent the growth and enlargement of the bacteria which are remained in the root canal system, because as you know, it's almost impossible to remove all of the bacteria, but the bacteria that are still present in the root canal should be so-called sealed of this root canal filling material. Because in this case, if these bacteria are sealed inside the root canal, they don't have supply of the nutrients, and also they don't have the space for their growth, and due to this, these bacteria are not able to be survival in the root canal system, and they will dead in some time. Also, root canal filling provide the prevention of penetration of the rest of toxins and bacteria to the periodontal tissues, and provides the sealing of pulp chamber and root canal system from the oral environment. So this is also really important. And finally, it creates a biocompatible closure of apical end, which allows the healing of the periapical tissues. And so, due to these aims, it's really important to provide adequate obturation, so-called 3D hermetic obturation of root canal filling. But before we will provide the definitive filling of root canal system, we should be sure that we have all of the conditions for obturation. First of all, it could be absence of clinical signs of the patient. It means that patient should be without pain, without some edema, and without some fistula. Also, we should be sure that we are able to provide the perfect drying of root canal. It means that there is no bleeding or exudation from root canal and no photo from root canal. Once we have some exudation or photo from root canal, it means that we still have some bacteria inside of this root canal, and we provide some additional shaping or additional chemical treatment. And the next condition for the definitive root canal filling, this is a perfect, correct shaping and its cleaning. With respect to perfect shaping, it means that we have taper shape of the root canal, and we also could to have the apical seat for our future filling, because our aim is to finish the root canal filling in the place where we finished our shaping. It means that mostly this is a foramen physiologicum. And finally, if we have for this puncture, we can have some microbial cultivation, and ideally it could be negative, but unfortunately, generally we don't have these tests for microbial cultivation. But with respect to the another conditions, we should be sure that we have all of them, and just in this case we are able to provide the definitive obturation of root canal system. So, which general rules should be used for the root canal obturation? Remember that shaping and a consequent obturation are in a close connection. So when we make the shaping, we provide the so-called simplification of root canal system anatomy, and so we create the ideal conditions for consequent filling making. Quality of obturation depends on the quality of shaping. We should to remove all of them, if it's possible, we should to remove all of the microorganisms. We should to create this taper shape, and we should to prepare the apical seat of the consequent root filling. Also, when we provide the shaping of root canal, we should keep in mind the anatomy of root canal and technique of consequent obturation. Before the root canal obturation, we should to dissolve the smear layer, we should to remove the remnants of dental pulp, so we should to provide the adequate, perfect root canal irrigation and disinfection. The obturation of root canal is provided using special materials. Most of them, or the most useful, the most frequently useful, is gutta percha. When we provide the proper compaction of this gutta percha in combination with special sealer. And finally, after we provided the root canal obturation, we should to make the X-ray image to check up the quality of our filling. And during this X-ray image, we will evaluate the length of root canal filling, we evaluate their homogeneity, and we evaluate some, for example, filling obturation of ramifications. So here we can see the list of requirements for the root canal filling materials. So ideal root canal filling material should be non-irritating, should be biocompatible with tissues, should provide the bactericidal or at least bacteriostatic effect, should lead to the hermetic obturation, should have perfect radiopacity, because we should be able to easily recognize this material on the X-ray photo, should not stain to the two structures, should have a good adhesion onto the root canal wall as well as gutta percha, should have easy handling and application into the root canal, should have sufficient setting time, should have mild expansion and volume stability after the mixing and application into the root canal, should be insoluble in tissue fluids, should be easy removal from root canal, and should be sterile or at least easily sterilized. Here we can see some classification of root canal filling materials that could be classified onto like 4 main groups. Some of them are not recommended yet, but let me say just for information that these materials existed or exist. So these groups are solid, semi-solid, paste and sealers. With respect to solid root canal filling materials, these were silver cones. They were widely used in something like 70s up to 80s years of 20th century. And nowadays they are not recommended. They had different sizes according to the size of root canals, and put into the root canals with some paste. The next group, this is a semi-solid, and here we can recognize mentioned above gutta percha that could have different phases. In more details we will say about in some minutes. The the next group, these are the pastes, and these materials are used separately without another cone, and nowadays this method is not so recommended, because these pastes had a high shrinkage, and so the application just of one paste, just of the paste, it was insufficient, was ineffective, inadequate. And the next group, these are the sealers that are nowadays widely used, but just in combination with gutta percha. So let's say some information about gutta percha. From Malay language, gutta percha means creates this name gutta percha, and these are the fibers of sticky tree sap. So it has like natural origin. As I said, we can differ three main phases of gutta percha: alpha, beta, gamma phase. With respect to composition of gutta percha cones, 20% this is the natural gutta percha, which is in chemical point of view so-called trans polyisopropan. Then we can find 60 up to 75% of zinc oxide, when we can find different metallic elements and sulfate to provide the radio-opaque opacity of this material, and also we can find 1 up to 4% of wax and resins to have like more, to receive more plasticity of the gutta percha. Gutta percha can have different color. Mostly this is a orange one, pink one, but also we can have another color signs, like we can see, for example, in this picture, and the end of this color size is colored according to the ISO color codes. So, gutta percha, this is an inert or so-called biologically inactive material that is non-allergenic, dimensionally stable. It also has some antibacterial property. It's radio-opaque, it's compactable, so this is an important property because we use a compaction method using the gutta percha. It could be softened by heat, by organic solvents, and it's relatively easily removable when it's necessary. So we can see that gutta percha has most of the requirements for the ideal root canal filling material, but unfortunately it doesn't have property to be adhere onto the root canal wall, and so it should be used in combination with special sealers. But before we will discuss the sealers, let me say some words about different phases of gutta percha. As I said, there are three phases: alpha, beta, and gamma. Alpha phase means that gutta percha will become flowable when we provide the application of the heat up to 50 Celsius degrees. In this case, we will receive some flowable gutta percha, and due to this flowable property, it's able to use so-called flowable gutta percha, hot gutta percha, in different techniques of the root canal obturation. Beta phase, this is a semi-solid phase, like normal cones, and if you provide the application of heat up to 50 Celsius degrees, it is changed onto the alpha phase. When we provide the further heating up to 60 Celsius degrees, it's changed onto the amorphous phase. And gamma phase, this is amorphous phase of the gutta percha. And as I said, gutta percha has almost all of these, or most all of the requirements for the ideal root canal filling material, with exception of the adhesion onto the root canal walls. And so, due to this fact, it should be used in combination with suitable sealers. So, general functions or main functions of sealers is the adhesion onto the walls of root canal, obturation of some ramifications, lateral canals, delta, and so on. Also, it provides some properties like lubricant for easier application of the gutta-percha cone during the obturation, and sealers also have some bacteriostatic effect. Some of them also could have a remineralization effect. So, which resins are available nowadays? Here we can see the list of most useful. So we can use zinc oxide eugenol based sealers. We can use resins based sealers. We can use GIC based sealer, calcium hydroxide based sealer, silicon based sealer, or calcium silicate, so-called bioglass sealers. So, let's say some words about different groups of the sealers. Zinc oxide eugenol based sealer, these types of the sealers are used relatively long time in the endodontics. They have long time of hardening. They are possible to be removed from the root canal if it's necessary. They don't lead to the staining of hard dental tissues, have antibacterial effect due to eugenol content. They provide the adhesion onto the hard dental tissues, but also they have bad mechanical properties and cytotoxic effect. So our filling is not allowed in this case because it could lead to the irritation and toxic effect on the periapical tissues. And one more disadvantage, these materials lead to inhibition of resin composites polymerization. So if we plan to use to provide the reconstruction of them using the composite materials, please don't use this zinc oxide eugenol sealer, or provide ideal isolation between this root canal filling and consequent composite reconstruction. Like representants, we can say, for example, pulp canal sealer, tubeless seal, or endometazone N. Resin-based sealers are maybe the most frequently used group of the sealers. We can use sealers that are based on epoxy, polyketone, or metacrylates resins. So, epoxy resin-based sealers, they are relatively widely used. They have long time of hardening, up to 2 days. They are hydrophilic, and so due to this they are able to penetrate onto the different ramifications, lateral canals, and so on. They provide the excellent adhesion onto the dentin. They have long-term volume stability, and they are resistant against the infuse. Also, they have some antibacterial properties in the beginning of the hardening, but they have some disadvantages, and maybe the most important of them, that they have really bad possibility to be removed from the root canal, because when they hard, they will be really hard like stone, and it's really difficult to remove them from the root canal. Also, they lead to the staining of hard dental tissues, and so it's impossible to leave some remnants of this sealer into the pulp chamber. After we finish the root canal obturation, we should remove all of the remnants of the sealer from the pulp chamber, and we should be sure that there is no sealer in the pulp chamber. If we leave a really small remnant in some time, we can see that these tooth will be stained up to the brown or a black color. So this is a really unpleasant disadvantage of this material. And also during the hardening they are toxic. Here we can see some representants like AH26, AH+. They contain from the powder and resin, or from the paste A, paste B, and they are mixed on the paper block using the plastic spatula, and finally they are used for the root canal obturation. Here we can see these sealers. Polyketon resin sealers have the similar properties like resin epoxide-based sealers. They have high adhesiveness of freshly mixed material. They have relatively high toxicity, and also it's really complicable, almost impossible to remove from the root canal. Like representatives, we can say, for example, Diacat A sealers. And methacrylate resin sealer, this is the next resin-based sealer. In this case, UDMA resin is used, and is used in some special commercially available materials. Some of them is the system Endores from Ultradent company. It contains the different canal, special sealers, gutta percha, for the application for the root canal filling obturation. Time of hardening is relatively large, up to 1 hour. The next group of the sealers that is possible to use, these are the GIC based sealers. Because they contain GIC, they have chemical adhesion onto the hard dental tissues. They're relatively mechanically resistant. They don't lead to the staining of hard dental tissues, and they have antibacterial properties. Also, they are hydrophilic, but they have a really large disadvantage that lead to almost to the fact that these sealers are almost not used nowadays. They have really short, and this disadvantage that they have really short working time, up to 6 minutes, and once they will be hardened, it's impossible to remove them because they are really hardened. They are non-resorbable, so almost no solvents are effective due to these sealers. Like representatives, we can, for example, say about Ketak Endo or Endion. And one more group of the sealers, these are calcium hydroxide based sealers that contain the calcium, and so due to this they could be effective, they could have active effect on periapical tissues because they are able to suppose the remineralization and creation of dentinoid tissue. They have antibacterial effect. They don't lead to the staining of hard dental tissues. They have easy handling, and they are biocompatible. They also provide the durable sealing of the root canal due to slight setting expansion, have long working time, up to 3 hours with respect to time of hardening. But some authors said that these materials are not so volume stable and could be resorbable in root canal. Like representatives, we can say about seal epics and epexite materials. Mostly they are placed in these special syringes, and when we put it, there is a mixing in this application cannula, and we will receive the material that is ready to be used. Silicone-based sealers, these are the sealers that are based on polyvinyl siloxane. They are biocompatible, hydrophilic, don't lead to the staining of hard dental tissues, and if it's necessary, they are easy removal. Like representatives, we can say about RCA sealer, Recaseal, Gutaflow, and with respect to disadvantage, this is their high price. Final group of the sealers that could be used nowadays, these are so-called bioactive mineral sealers or calcium silicate sealers, so-called bioglass. They have outstanding adhesion to the dentin and gutta percha points. They're hydrophilic. It means that they are able to continue the sealing process in the presence of some moisture. They don't stain the teeth. because have the mineral content. They don't have resin. They are made from pure calcium silicate without monomer, and so in this case, due to this, there is no shrinkage of these materials. They have good flowability, so they are able to seal some ramificant, some lateral canals. They are used with so-called cold single cone or cold lateral compaction methods. They have high radiopacity, but if it's necessary to remove them, it's really complicated because they are really hardened after the hardening. Like representant, we can say about, for example, Beirut RCS sealer, but nowadays, of course, there are another one. So now we will discuss the possible methods of root canal filling. As I said, we use a gutta-percha in combination with sealer, and with respect to gutta-percha, we prefer to use a compaction method. These compaction methods could be cold or warm. Cold, it means that we provide, or we will choose, we are able to use a cold lateral compaction. With respect to warm compaction methods, we can use method that used warm gutta-percha that provide or that lead to the warming of gutta-percha in root canal, like warm lateral compaction, warm vertical compaction, or thermomechanical compaction. And also we can use the warming of gutta-percha outside the root canal, like thermoplastic injection technique and carrier-based gutta-percha. And finally, we can also use some single cone method, but I'll say in which cases, and now let's discuss this method techniques in some details. So, cold lateral compaction. This is a really simple method, or relatively simple method, and it's undemanding for material and devices. In this case, there is a low threat of overfilling of the root canal. It has low threat of leakage because the contraction of cooling gutta-percha. This method is used for really long time, so it has good long-term results and suitable for most clinical situations, with exception of some severely curved or abnormally shaped canals with some irregularities, like for example internal resorption. And with respect to disadvantages, this method is time consuming, and because due to this method we will use some strain, some pressure onto the root canal. Due to this, there is a high occurrence of vertical fracture, and usually the filling on this X-ray photo is not homogeneous. So what we should do, or what we will do when we decided to fill root canal using cold lateral compaction of gutta-percha. First of all, we should be sure that we have a perfect ideal shaping of root canal, tapered root canal with apical seat. Master apical cone has to have same diameter like master apical file. It means if we finished our preparation using, for example, ISO 40, our master apical cone should have the same ISO size. For this aim, we will use the special instruments like spreader that are plain on the side and have some sharp tip. And this spreader, it's necessary to provide the correct choice of the correct size of the spreader. This spreader should be insert up to 2 millimeters to the working length. Usually this is a half of diameter of master apical cone. Then we should to choose the accessory cones that are usually 1 up to 2 ISO sizes smaller than spreader. Then we should use a sealer, and finally we should use a plugger of adequate diameter. So if we look at this picture here, we can see this technique step by step. So first of all, we put the master apical cone and it should be finished. It should be seated in the place of apical seat. Okay, so we put it into the root canal. We will check up it using the tweezers. We should to sign the working length of this cone, and if this working length which we signed on the cone after the removal from root canal is the same like our working length, it means that we provided a good shaping of root canal and that we were precise. If this working length is shorter, it means that we have some apical stop or we have some problems in apical part, and we should to provide the reshaping of root canal. And if this length after the signing is longer, it means that we don't have apical seat and our master apical cone is extruded, so it means that we should to provide the reshaping of this apical seat. But if we, after the checking of this master apical cone, if this length that we signed on the this cone is the same like working length, it means that we were successful, and then we can start to fill our root canal. First of all, we'll mix the sealer and put the sealer using the some small hand instrument onto the root canal wall. In this case, please don't use a lot of sealer, just a small amount, put it onto the canal walls, then put a really small amount onto the master apical cone, and gently put this master apical cone until it will finished on the apical seat. Then we will use the plugger, the spreader, like we can see on the picture, and put the spreader along on the master apical cone, and also gradually we will press on this spreader, using this spreader onto the master apical cone onto the side. Please be careful in this case and don't press too much onto this spreader. Then we leave this spreader to 1 up to 2 minutes. So we can prepare the this additional auxiliary gutta percha cone. Then we remove the spreader really gently. Then put the auxiliary gutta percha cone, and in this case we put just tip of this cone onto the sealer. Put it onto the space that is created after the removal of spreader. Then we all put the spreader once more and repeat this procedure. So using the spreader, we press onto the auxiliary gutta percha cone, then we remove it, put the next auxiliary cone, and continue until we will fill all of the root canal and our spreader is placed just up to 2 millimeters onto the root canal. Here we can see the scheme of this root canal that was filling using the gutta percha, using the lateral compaction of gutta percha, and here we can see like on the cross-sectional root canal. Finally, using the some heat instrument or some special heating device, so-called hot plugger, we will remove these remnants of the gutta percha cone, and our aim is to remove all of these cones up to 2 millimeters under the root canal orifice. Finally, we will use normal plugger, like cold one, and provide the vertical compaction of the gutta percha. And so that's it. After this, we should to make the X-ray photo and check up the quality of root canal filling. Here we can see once more cross-section on the scheme of cross-section of the root canal that was filling using the using the lateral compaction of good aperture. Master apical cone point, sealer, and different accessory points. Here we can see the table for the better choice of spreader and accessory cones according to wine. So we can see, or we will provide the choice of the spreader according to the master apical cone size. We can use a special we can use normal ISO sizes, or also some spreaders can have A, B, C, D sizes, like CD larger, medium. They are used in the case of master apical cone larger than ISO 55. B fine is used in the case of 35 of up to 55 ISO size, and A extra fine is used in the case if ISO of master apical cone is less than 35. And as I said, also we can use a ISO sizes like we can see on this table. The next method that is also be able to use for the root canal obturation, this is a warm lateral compaction. And in this case, it's not necessary to use so large pressure on the spreader, and so there is a smaller occurrence of vertical fracture. And special use of special device is requirement, like we can see here, for example, endotwin system that provide the heating of the this spreader, so-called hot spreader is used. With respect to principle, this is the same, like, but the main difference that this spreader is hot, or provide is able to be hot, and so it provides the application of heat onto the good aperture during the lateral compaction. The next method, this is the warm vertical compaction, which is also able to be used for the root canal filling. In this case, we will use them. First of all, we should seal the apical part of normal called good aperture. So we put the good aperture cone like master with the same size like master apical file. Then we put the hot plugger and cut it, leaving the like some millimeters, 3 millimeters onto the apical part. Then we remove this remaining part. Of course, first of all, we should put the sealer, because, as you know, good aperture is not used without the sealer. Also, in this case, we will use a really small amount of the sealer. And after we will seal this apical part, we will put the next good aperture cone. And put the heat, and gradually leave something like 2 up to 3 millimeters of the good aperture, and gradually we will fill all of the root canal. Finally, we provide the vertical compaction using the normal plugger. With respect to advantages, it provides the perfect obturation, but also on the other hand, this is underside. This is a time and skill demanding. It's time consuming, and it's necessary to have some manual skills to realize this method. With respect to indication, these are the same like for lateral compaction, and it's suitable, for example, for the internal resorption or other situations involving internal morphologic complexities of the root canal system. Also, we can use, for example, so-called methods for vertical obturation, warm obturation, like system Calamus, or for example system Bifill. Also, they provide the application of a flowable, so-called hot flowable good aperture, like thermal injection method. The next method, this is a thermomechanical compaction that is quick and provides a good obturation of the lateral canals. but also it's necessary to have some manual skills, and it's not so useful for curved canals or canals with larger apical foramen. Also, be careful, because during this method there is a creation of relatively high heat inside the root canal, and if this heat will be really large, it could lead to some damaging of the periodontal tissues. When we use this method, we put the gutta percha cone into the root canal. Then we use a special rotary instrument, gutta percha compactor, in the blue handpiece without autocooling, up to 10 up to 12,000 rotations, and put this instrument along the gutta percha, and during the rotation of this instrument, the gutta percha will be delivered like deep into the root canal and also onto the sides of the root canal, and this compaction is provided. The next method that could be used for the root canal filling obturation, this is a method that provide the warming of gutta percha outside the root canal. One of them, this is a carrier-based gutta percha that is used in a so-called system Thermafill, ProTaper obturator, or Gutta Master or Gutta Core. It's relatively quick and simple, but also here there is a high risk of some overfilling of root canal. It's unsuitable for curved root canals, and sometimes there is a risk of loss of gutta percha if we were not successful at the first time. The principle of this method is that we use special carriers with gutta percha. They could be plastic, like for example in the case Thermafill or ProTaper Wave 1 obturator, and this plastic core is covered by gutta percha. But also this core could be done from some specially prepared gutta percha, like in the case of Gutta Core, and in this case there is no plastic inside of this obturator. These obturators could have ISO sizes according to ISO system, like for example Thermafill Gutta Core 1, or they could have the specific special sizes that are suitable for the specific root canal rotary instruments, like for example ProTaper, Wave 1, and so on. For the realization of this method, we should have the specific warming device, and when we provided the mechanical shaping, irrigation, drying of root canal, we should check up like this working lens, and we should to use some special instrument that is named verificator. This instrument will provide to us information if we have all of the apical seed, and if the shaping is the same, is suitable for the future obturator using. So when we provide the choice of suitable obturator, we put it into the special warming device where we should choose the correct size of this obturator, and finally we can turn on this device. During that time we put a little really small amount onto the sealer, onto the root canal, and when we will hear acoustic signal, we can put this obturator and start to fill it. It's really easily, and we put it onto the root canal until this rubber stop will be onto the working lens. Also there is some specific like lines that give us the information about this length of the obturator. we have 18, 19, 20, 22, 24 millimeters. Sometimes it's some of authors recommend to cut the really short part of the tip to prevent the overfill. When we have this wound obturator, when we have the really small amount of sealer into the root canal, we just really gently put it onto the root canal until this rubber stop will be on the walking lens. In this case, we can inform the patient that they can feel some pain because when they have anesthesia, because in this case the air that could be present in root canal will be delivered deeper and deeper, and this is felt by patient like pain. When we put it onto the whole walking lens, we should to remove the remaining part of the carrier. If it's based on gutta percha, it's really easy. We just remove it using our hand or using, for example, some instrument, hand instrument, and provide the vertical compaction using the plugger, or if we use a classic thermofill with plastic core, in this case we can use a special instrument, thermocut, special rotary small instrument thermocut that is used with turbine handpiece with smaller slowest rotations without water cooling, and our aim is to remove this core up to 2 millimeters under the root canal orifice. Finally, we should to provide the vertical compaction using the plugger, and consequently we can or we should to make the X-ray photo and check up it onto the photo onto the root onto the X-ray picture. The next final method that could be able to use to provide the definitive root canal filling, this is a thermoplastic injection technique. So in this case, gutta percha will be warmed up in special warming device and is delivered through the special dispenser syringe, and it's so-called injected into the root canal in around 2 millimeter layers and condensed with pluggers. But first of all, we should to seal this apical part using the suitable cold gutta percha cone, remove remnant part, and finally we can gradually inject the gutta percha, flowable gutta percha onto the root canal up to the requirement length. With respect to advantages, in this case, there is a great ability to fill the lateral root canals and ramifications. And also, it's possible to end our filling in the requiring length. And for example, if we know that we should to have the space for the post and core, we can finish our filling in the middle sort of root canal, and so we save our time with respect to removal of some part of the gutta percha. But in this case, if we will not provide the adequate sealing of the apical part, there is a high risk of overfilling, and also this is a time consuming, and this device also is not so cheap. For example, some different systems like Obtura 2 Ultrafill and another one could be used in this for this aim. Here we can see this is an injected gutta percha injection of so-called injection of flowable hot gutta percha into the root canals. And one more method, so-called single cone method. This single cone method was used some years before, and in this case just one master apical cone, gutta percha cone, in combination with sealer is used. Without any compaction, without any auxiliary gutta percha cones, and logically that it didn't provide adequate sealing of the root canal system, because the sealer has a great part of the filling, and consequently in some time the resorption of this sealer could be present. Some modification of this method that is used nowadays, this is a so-called single taper method. So please don't change this method. Single taper method means that, for example, we used some gutta-percha cone with larger taper than ISO, normal ISO. For example, different rotary endodontic systems of instruments have the specific gutta-percha cones with adequate taper, and these specific gutta-percha cones could be used with some sealers. For example, bioceramic sealers is used with single taper method when we put the gutta-percha of special tapering in combination with these sealers. But please, once more, don't change these two methods. Disadvantages I said about this single cone method in this case is there is a creation of space between gutta-percha and root canal wall because in time we can see the sealer contraction, and also it's almost impossible to fill the lateral canals and ramifications. So nowadays it's not used, but as I said, some of modification like single taper method is used, especially in combination with bioceramic sealers. Like summary of root canal obturation, I could say that definitive obturation of root canal system could be provided just in the case of absence of clinical signs of the patient, and if we provided the perfect mechanical and chemical treatment of root canal system with preparation of apical seat in the apical part. The main useful root canal filling material, this is a gutta-percha in combination with suitable sealer. And finally, when we provided the obturation of root canal system, we should provide its evaluation on the X-ray picture when we evaluate the length of root canal filling, its homogeneity, and some obturation of lateral canals and ramifications. Thank you so much for your attention, and I will wait for your questions or some comments. Thank you.